Wonderful.
Let's do it.
All righty. Well, welcome everyone.
Ooh, the room's filling up, Frank.
Wonderful, wonderful. Thank you all for coming. So what's the weather in Detroit right now, Mark?
So it was about maybe 74, 76 today, low humidity, so it was a little cool. I don't, this is being recorded, but I wouldn't want the world to know. Maybe I snuck out and played 9 holes in the middle of the day today.
Well,
I've
you do have a nice tan, so I can see you might have had a little sun.
The beauty of working from home is I'll get up in the morning early. We were just talking about getting up so early, and I'll work my butt off. And then around 11:30, 12 o'clock, I'm starting to get the itch. And my wife had an event to go to this afternoon. So I texted my buddies and we grabbed a 1:10 tee time and we got in fast little 10 holes. Actually, we played nine, and then we only have a 9 hole club here. And then the first hole leads right back to my house. So we
So
actually,
my concern there is, what about the 19th hole? If you only have so
I'm
many, how do you
I'm
work
a
that? You go
boring
out around
coffee
twice?
guy. Yeah,
You
I'm no
go around
fun.
twice?
So I guess that would have to be the 10th hole then for us. But
The
we have
10th
two
hole.
different sets of tees, so you play it around twice, but not today.
Wonderful. And a little bit of coffee
Yeah, for
or
sure.
tea.
Well, Frank, I think we're about ready to get started. We've got a bunch of
Great.
folks in the room, so that's good.
Everyone, thank you so much for joining. Typically we give it a couple more minutes if that's okay. Or
Sure.
you ready to? Let's give
Well,
it
it
about two
is
more minutes.
recorded, so it's going to take us a couple minutes to get started on anything exciting anyhow. So I don't think they're going
That's,
to miss anything.
I agree. I agree. Everyone, again, thank you for coming. So let's get it started. Let's get it started. I'll do a quick introduction and here we go. Um, Well, number one, everyone, thank you so much for joining our webinar. We do this monthly. We hold monthly webinars, and if there's anything that you suggest that you like to learn about or interested in, please let us know. We'll be happy to bring the right resources in to help us with that. Just a little bit on the Zoom. You are on speaker view. Your camera is off, and you're muted for the webinar. So if there are any messages, please, put them into the chat. Any questions, put them into the chat box. We can, or in the Q&A, and we're happy to share those, any questions with Dr. Murphy, and we'll interact in that way. So for today's topic, best practices review, patient acquisition, testing, treatment, and getting paid. Um, Let's see here. Your live attendees will receive a promo code at the end of the webinar, so please stick around. We have some specials for you. Definitely something special for IAOS. And let's see here. A little bit about True Function. We've been doing this for about 26 years now. So started the company in 1999. And where we pride ourselves is we are strong supporters of education. So we love sharing knowledge with you, bringing in great experts like Dr. Murphy in, and supporting courses for clinicians and just being a part of that. Um, we do have a clinical director available to guide you through the clinical process or any concerns you might have. And the most important thing is we got great people, wonderful people that are always here to support you. And the way we make our decisions is always decide in the best interest of the patient and the clinician. That's our goal. So here comes the important part. I'd like to introduce you all to a good friend of True Functions and a great friend of mine, Dr. Mark Murphy. Dr. Murphy, we've known each other for 16 years, I believe you said,
Yeah,
since
I know when
2009.
I started to think about 2009, I went, holy crap, we've been hanging around a
Yeah.
long time.
So Mark, yeah, I was telling you, I used to have hair, I think, back then. So
And
it's
mine
it's been
used
a
to be your
while.
color. That's the difference, right?
It's just amazing how time flies, and I'm so blessed to have your friendship and your support. So a little bit about Dr. Murphy. Again, we met in Denver at an NADL University course. You were teaching, and I was learning. Um,
I
so
just say we
you're
were studying together. We were both learning at
you
the same time.
you're absolutely a mentor to me, and again, it's a blessing. Uh, currently, Dr. Murphy is lead faculty and executive director of Restful, powered by IAOS. He's been involved in DSM since 1999, serving on the guest faculty at the University of Detroit Mercy School of Dentistry, and was a regular presenter on sleep and leadership at the Pankey Institute. He lectures internationally on business development and dental sleep medicine. And he has a knack for presenting pertinent information in an entertaining manner. So, welcome, Dr. Murphy. The floor is yours. Thank you so much. We're glad you're
Thank you,
here.
Frank. Thank you. Yeah, back in 1999, when you were starting the dental lab, I was teaching down at Pankey with a guy named Keith Thornton. And of course, he's the
Yes.
T in the TAP device, Thornton anterior positioner. And we were teaching a TMD course. I know you're big on TMD, you make all kinds of great devices and stuff like that. And so, but he was telling me that if I'm treating TMD like I was and chronic pain and fibromyalgia and stuff in my patients, I needed to know more about sleep. So he convinced me way back then to start making these very crude sleep devices look like an upper impression tray with a handle sticking down, and a lower arch had a flat area for that handle to hit on. And you couldn't
Yeah.
close until you stuck the mandible far enough forward that you could close down. So horrible devices. And we made those for years. And then I got to this point where I started to think, it feels like we're practicing medicine without a license. We're not physicians, we're not getting people tested. We're helping them, but we're not doing it the right way. So I started to quiet that down and just stayed with my TMD practice. And then in 2012, I was diagnosed with sleep apnea and made myself my first device, a pink one. I'll just say that because I didn't know you and didn't get a device back then. And my previous life with Prosomnus, they weren't in business yet or anything like that. So, and then of course, the rest is history in terms of evolving back into sleep. And then for me, what got interesting is a couple of years ago, I got diagnosed with AFib, as a lot of sleep apnea patients
Wow.
do, and an aneurysm in my ascending aorta. So I've been slowing down, Frank. So you and I used to travel a lot and teach a lot, and so now I'm trying to slow down. So a lot of the stuff I used to do, I'm doing a lot less of. So I'm happy to do a program with and for you, of course. Uh,
Thank you. Yeah.
I started a program down at University of Detroit. I used to teach in the program at um, the Pankey Institute. I've really published a lot of articles and stuff. Been very involved in sleep. I'm boarded with the American Board of Dental Sleep Medicine and with the iOS. So that's my credential statement, my conflict of interest. I'll have my email address on the last slide before your promo codes, and it's mark@ios.com. So anybody wants to reach out to me, wants a copy of the slides or anything, feel absolutely free. So we're going to talk about best practices tonight, but I'm going to set that up by talking about, I think, why so many people are looking at dental sleep medicine, why so many people are getting into dental sleep medicine. And there is this obvious, incredible economic positivity to it. I mean, dental sleep medicine is responsible for about 5 to 6, maybe 7 times the hourly income that you can make as a dentist. So that there's people literally practicing a day and a half a week and having $1 million sleep practice. So there's this financial attractiveness to it that everybody gets excited about. But I really want you to think about that is the result of helping people breathe better at night. That is the result of you and your team doing things that are worthwhile and fulfilling and inspirational and really make you feel good about what you're doing. And then, oh, by the way, isn't it great that it gets paid so well? And oh, by the way, you don't have all the hassle you have with dentistry, because in dentistry today, we're seeing an awful lot of headwinds. We've got a lot of things that are beating us up in terms of costs are going up and reimbursement seems to be going down, and there's a lot of challenges. So trying to find a way to either become less dependent on dental insurance, less dependent on that income stream, which is declining, and finding alternative sources of income. A lot of people have gotten into implants or ortho and Invisalign or third molar extractions and all this other stuff. And that's fine if that's your passion, but those also require a fairly high level of clinical skills. So for a lot of people, getting into dental sleep medicine solves that problem. This is the American Dental Association's Health Policy Institute's data showing that, and it only goes back to 2010. You can go back all the way to 2005. We've actually been seeing a year-over-year decline in the average dentist's income since 2005. To date, it's about 20%. Now, if somebody came into your life and took away 20% of your income overnight, you'd call the police or you'd sue them, you do something, rash. But if they took away 1% every year for 20 years, you might not notice. And that's what's been happening because reimbursements are going down, And we're working harder. The Health Policy Institute says the average dentist is seeing more patients, doing more procedures, working more hours, 1,775 hours on average. A dentist is working in the United States. The average practice is around 800,000. So that means it's about $427 an hour average production for the average dental practice. Your practice might be much better than that. That's great. High five. Put them all together. Average is 427. Take away hygiene, and it's about 305 or $310 per hour. But in dental sleep medicine, even in some really modest parts of the country, it's hard to spend more than an hour and a half on a case. And it's hard to get less than $2,500 to $3,000, although we get lots of our members are reporting between $3,000 and $4,000 and some over $4,000 as their average reimbursement. That means they're getting somewhere between $1,600 to $2,000 to $2,200 an hour, 4, 5, 6, 7 times what the average dental practice can make. That's why so many people are finding the lower stress, better balance in their lives, better economic rewards, all of that in dental sleep medicine. And I don't have to tell you that. But what is surprising to me is why aren't there more people doing that? We got a couple 100,000 dentists in the country, and we think, we're not sure the exact number, but around 100,000, maybe it's 110, 115, have ever taken a sleep course. This isn't a sleep course. This is kind of a highlighting best practices course, but have ever taken a sleep course. But only 6,500, maybe 7,000, but certainly not 8 or 10,000 have ever made an oral appliance for a sleep apnea patient. Wow. Wait a minute. That's 6.5% of the 100,000 that have taken a course ever went as far as to make an appliance for a patient. Of those, we know this from insurance data, only about 15 or 1,600 have ever billed successfully medical insurance. Wow, the number keeps going down. Now we're at 1.5% of the 100,000 dentists have ever made an appliance and successfully billed medical insurance. And from my previous access to industry data, we know that 350 to 400, maybe 425 or 50, but not 500 are really doing sleep, really have a sleep practice, or maybe have a day or day and a half in their dental practice that's sleep, where they're doing 15 or 20 devices a month. And a lot of those people went through a program like ours through Restful, powered by the International Academy of Sleep. And the real reason that there aren't more is because it's really hard to develop a model that predictably gets you paid. So one of our best practices tonight is going to be talking about how do we get paid. We're going to talk about patient acquisition as one box of stuff that you get to make decisions on, where am I going to get my patients from? And then another box, all the different kinds of sleep testing relationships, local referrals, initiating it out of your practice, working with the telemedicine, all the different options. And you can do most of those in all the states. And in 4 or 5 states, you can't dispense or order a sleep test, but most of the states you can. And then, of course, there's all kinds of treatment options. That's what Frank is here for, True Function. He's there to help guide you with the decision about which type, which sort of precision oral appliance, because he's got milled and he's got printed nylon. So he fits into that family of well-made precision oral appliances, getting that patient treated and then getting all their follow-up visits and stuff. And then, oh, by the way, this documentation and billing, those 2 words have to be linked as one word almost, because if you don't have the right documentation, you don't get paid. So let's start with this patient acquisition box and talk a little bit about where we get our patients and what are some of the best practices for getting patients in your practice. The traditional acquisition models would be, you could do internal marketing. You could screen your own existing patients. You could do external marketing, whether it's TV, radio ads, anything like that. Not an issue. All those things can be beneficial. And then the traditional referral models, rather than straight acquisition, would be working with local sleep physicians, working with other types of physicians as well, and working with other dentists who might not want to do sleep. And then there's a third sort of a model, which is one of the ones that we've kind of made famous at Restful iOS, and that's the medical office referral model, where you actually build another business, and that business then contracts with a medical practice that's not a sleep practitioner, primary care, cardiology, endocrinology, et cetera. And they create a testing activity in their business with that business model and refer patients to you or for CPAP and back to sleep physicians. But that testing gets done over there. So it gets initiated, creates a real sustainable model. We're not going to spend much time on that. That's a very advanced model for somebody that's doing 20, 25, 30 devices a month and wants to grow to 50 or 100, Yeah, if you've ever heard Brandon Hedgecock talk, I think last November, December, he did almost 400 devices a month. It's just crazy to think about that. And as he loves to tell the story, it's not like he actually took any of the impressions or delivered any of the devices, because this is a very auxiliary friendly model. When you're thinking about how we're going to market to our ambient population of patients, there's this example of thinking about all of the different passive communications versus, let's call them intentional or active kinds of communications you could have with patients. And whether it's social media posts, having a website that's separate from your dental website, that's very OSA specific. I've seen great displays in the reception area. I've seen models. There's some great ones. Aaron M has one that's available if you're at the Dental Sleep forum on Facebook that he sells. It's handy for a lot of people to use. I've seen trifold displays. You can hang your credentials up if you're bored in sleep, you're a qualified dentist or a diplomate. You can certainly do press releases, video loops, statement stories, all kinds of things you can do. And everybody's going to find their own mix of active communication that creates a passive marketing activity. Even though you activate this level of activity, it's passive communication. They read it, they see it, and they have to come in and ask about it. And they do. They do. Not in the numbers most of us would want, but if you've got a poster in the waiting room, or you've got a video playing, or you've got some brochures out, or they've seen your social media posts, or anything like that, they might say to you, hey, I saw that thing out there. My husband, my wife, or I think I might have. I've got a friend that, and it starts a conversation. Love those bluebirds that come walking in. Absolutely imperative. And then certainly, of course, you're going to have patients that are sitting in your hygiene chair where you and your hygienist are going to have an opportunity to see whether it's wear, tori, scalloping is just a dead giveaway. And of course, the combination of wear, just to tie this together, is in those movement disorders as a classification, about an 85% correlation between bruxism and obstructive sleep apnea. So that's important. Anytime where you've got a discrepancy between the size of the tongue and the size of the bony box that houses it, you're going to have a patient that's likely to have scalloping and likely to be affected by obstructive sleep apnea. If you've got a large overbite or overjet like I've got, large tonsils, anything where you think it might be challenging, again, those are things you can notice. You can fire up a conversation with the patients about things like that. What I want to do in terms of talking about best practices is we could talk about meeting with local sleep physicians and doing lunch and learns and getting past the gatekeeper by asking what you can do for them in terms of referring patients instead of them sending you patients. We could talk about meeting with dentists and doing lunch and learns and teaching them how to screen in their practice. It won't be a very robust source, but you might have 4 or 5 or 6 friends who aren't going to do sleep, who trust you to not steal their patients. Be a great resource. We could talk about those kinds of opportunities. We could talk about more marketing activities, but the diamonds that are right under your feet are the 2 or 3,000 patients you have in your practice that you could actually intentionally have a conversation with to talk about obstructive sleep apnea, that you could screen those patients and segregate the 25%. So if you had 2,000 patients, that would be 500, 90% of them, 450, have never been diagnosed, never been treated. So 450, even if only half of them, you could move forward in a conversation. That's a couple hundred or so. And if you did 1 or 2 of those a week, it would take you 2 years at 2 per week to work your way through all those patients. So there's a gold mine, a diamond mine sitting under your feet. And the intentional conversation that I would encourage you to have is with this tool called the Epworth Sleepiness Scale. It's required by a lot of insurance companies. So our software mandates that you put in the stuff for the Epworth Sleepiness Scale, even though it does not correlate very well to whether or not the patient has sleep apnea. It's a great conversation starter. 8 questions, 0 to 3. How likely are you to be drowsy or doze off after lunch, sitting in a car at a traffic light, having a conversation with somebody if you lay down for a second in a conversation, any of those kinds of things. You score that. 11 or more is considered excessive daytime sleepiness. Wow, cause for concern. An alarm bell goes off. But there's lots of reasons people can be tired, not just sleep apnea. And if you have a low score, they don't have a high daytime sleepiness score. But there's lots of reasons for that. Even patients with sleep apnea, some of them caffeinate. I mean, the number of Celsius drinks, Boost energy drinks, Monster, cups of coffee, guilty. that people drink to caffeinate and keep themselves a little bit more excited through the day means that they might underreport on the Epworth Sleepiness Scale. Bottom line is, it's a poor predictor of whether or not a patient has sleep apnea. But you don't care. Because what you do care about is the 8 questions you could ask them called the stop bang. The stop bang is, do you snore? Are you tired? And you might get that from you don't know whether they snore or not, but you might get whether or not they're tired from the Epworth Sleepiness Scale. You don't know whether their spouse has ever seen them or a bed partner has ever seen them have an observed stop breathing, but you do know from their medical history whether or not they've got a comorbidity or they're hypertensive, GERD, diabetes, cardiovascular history, anything like that. You can gauge whether they're carrying a few extra pounds. I'm 6'3" and 230 pounds, and I've got a BMI of 29. So you don't have to be a monstrously large person to have a BMI that's 30 or larger. Most NFL football players have a BMI that puts them in the obese range, not overweight, obese range. If they're over 50, that's a risk factor. If their neck size is 17 or more for men, 15 for women, risk factor. If they're male, risk factor. So if you looked at me, for example, do I snore? I do. Tired? Never. Observed stop breathing? No. A hypertensive or anything else like that? Yep, I happen to have AFib. So that's 2. Is my BMI 30? Nope. Is my age 50? Yes. Is my neck circumference 17 or more? Yes. Gender male? Yes. I have 5. If you have 4, you're at high risk. If you have 3, you're at risk. If you snore and are tired, you should probably investigate that person as well. So there's some fancy things. You can read the article about the stop bang analysis in the American Thoracic Society's journal CHEST. And the resource people for the lab can probably get you access to that if you needed to look at all the different algorithms about the different combinations. But 3 is at risk. 4 is high risk. What does that mean? 92% likely to have sleep apnea if you have 4 or more of those factors. And so I should be tested. So you use the Epworth Sleepiness Scale. How? Thank you for asking. Well, because I have all these other things, and I just want to ask them about snoring and observed stop breathing, but I put them in this risk category. I start the conversation using their Epworth Sleepiness Scale with, hey, Mr. Jones, I've noticed here you had a high score on the Epworth Sleepiness Scale. That's one of the risk factors for obstructive sleep apnea. Has anybody ever talked with you about that? No, they haven't. Well, with your cardiovascular history, your age, the fact that you're a male carrying a few extra pounds, being tired during the day, that's 5 risk factors you really should get tested. And so we have a conversation from the Epworth Sleepiness Scale that leads into the stop bang. Now, what happens if the Epworth Sleepiness Scale is 3 or 2 or 0? Well, I start the conversation the same way with Mr. Jones. Mr. Jones, I noticed here you had a really low Epworth Sleepiness Scale score. That really surprises me. Instead of it doesn't surprise me, now it really surprises me because you have several of the other risk factors. You've got the cardiovascular history, you're carrying a few extra pounds, you're over 50, you're a male, your neck size is probably 17 or larger. You've got 5 of the other risk factors. We really should get you tested. So see, this best practices for getting patients is looking at your own patient population, screening them, and using this idea of an intentional conversation that starts with a screener that should be part of your intake health history and your update health history. That will generate, in the average practice that becomes proficient, you won't be proficient the first 3 or 4 or 5 weeks, but you will get better. That will generate 1 to 2, 3, maybe 4 prospects a week, half of which end up getting tested. That's 2 a week getting tested. That's 8 a month. If half of them, 4, now you're at 4 devices a month. And as you become better with it, 4 maybe becomes 6. And while you're moving from 2 to 4 to 6 devices a month, you've got the opportunity now to go out and talk with dentists, talk with other sleep physicians, and gather that referral source. It's a great way to start best practices for screening. When they move into the testing box, and I'm not going to teach testing and the different types of tests and how to interpret the tests or anything like that, I want you to think about 2 different types of patients. Patients that come in, excuse me, from a sleep physician, already tested, letter of medical necessity, and a prescription for an oral appliance. Boom, check the box. Let's rock and roll. Get that patient scheduled. Their physician, not you, their physician has recommended this treatment, which you can provide. It's a medical problem. treated with a medical solution that happens to be provided by a dentist. So it's all about the physician ordered, the physician's prescribed, the physician's recommended. You're just filling a prescription. And that gives you an opportunity to get started. That's great. We're not going to talk about those either. We're going to talk about the ones that need a test. Well, if they need a test, I can either send them to my local physician. A lot of times they disappear in the CPAP world and they never come back. But you will need to develop some relationship with some physicians. And if part of your talk track with a local physician is, I'll send you some patients, you should. Who do you send? The PITAs, the complex medical histories, the complex sleep histories. You send the really complex patients to your local physicians to fulfill the promise that you would send them some patients. You could also dispense a sleep test in all but about 4 states. You could dispense that sleep test and get the ball rolling. It still has to be interpreted by a physician. You can't read it. It has to be interpreted by a boarded sleep physician. You could do that. I don't like to because then it looks like I'm selling them or something like that. We've had some really good successful models inside Restful and our members where they use that as a screening tool and then recommend a sleep test. That works out great. Or what I like to do is send them to a third-party telemedicine visit. I say to them, we have a couple options here, and as long as they don't have this complex medical history and I don't offer them an option, then I say, we've got a couple of options here. I can send you a local sleep physician. Usually it takes a few weeks to get in, might take a few weeks to get tested after that. Sometimes it takes a little bit of time, or we can do that through telemedicine, and they go, I want that telemedicine visit. And you won't have to get sleep tested in a lab very often. It's almost always a home sleep test. Oh, I want that. So yeah, so I'm going to give you this number. They're going to reach out to you. They'll try 3 times. So please respond to them when they call or email you. And we connect them with one of the services, whether it's Rest Assured, sleeptest.com, West Coast Diagnostics. There's some really good companies out there. And they will reach out to your patient, do a telemedicine visit with a physician who's board and sleep. They'll order up the sleep test, mail it to the house. They'll wear it for 2 nights. They'll mail it back. They'll do an interpretation. And if the patient has sleep apnea and it's mild or moderate, one of the first choices for them will be an oral appliance. If it's severe, or if they have too many central apneas, then they're going to push them towards CPAP. That telemedicine probably was 75 to 80%, maybe a little higher than that, of the patient flow we had to get them tested because A, we can connect them with that sleep testing capability within a week. B, if they're responsive, they could pick a time that's good for them to take the test during the following week, and they ship the test out right away. So within a couple of weeks, we've got them tested, and usually within a week or so after that. So in the course of 2 or 3 weeks, we've gotten them tested, got the results back, we've got the sleep test, we've got the prescription, and then we reach out to them and say, hey, Mrs. Jones, your physician who you saw for that sleep test has recommended for you an oral appliance. Let's go ahead and set up an appointment to get you in and get started. Works out great. Keep in mind that there are 4 types of tests. There's an attended full channel test. There's an unattended full channel test. You'll rarely see those anymore. I do use occasionally the Z machine from General Sleep, which is a type 2 test, full channel. Got a hypnogram and everything like that. But most of the time, you're going to see a type 3 test. It's unattended, no hypnogram. And then occasionally you'll see unattended with limited channels like a pulse oximeter or something like that. We're starting to see more and more of that technology being applied. Sleep tests come in a lot of different forms. You get to see lots of different ones. These are all type 3 tests, whether it's a ring on the finger, whether it's looking like a pulse oximeter in a ring with a little sensor that comes over on your chest in the WatchPap 1. There's a Medabite Junior and a ResMed ApneaLink Air. Aries is the one that goes around the head. All these are viable tests. You want to make sure that you're working with a good testing company who keeps in mind what sleep tests some payers, some insurance companies will or won't pay on, because there are those occasions where there'll be a sleep testing company, there'll be a payer for medical insurance who wants an effort belt, who wants a nasal cannula or some sort of specific thing, and you want to make sure that your testing service can provide that. Even though diagnostically it might be acceptable by the physician, you want to make sure that it's payable, because at the end of the day, if I can't get you paid at the end, you're going to be doing 1 or 2 devices a month the rest of your life, and you'll be doing them for cash, and you'll never develop a business model. Patients are doing a lot of testing themselves. This is SnoreLab on the left, an actual patient, friend of mine who's a pilot. Treated him, his snoring score went way down, his sleep got better. But patients are wearing, whether it's an Apple Watch or a Fitbit, my Sleep Number bed has technology in it that tells me how well I slept last night, what my respiratory rate was, how much I tossed and turned, heart rate, gives me a lot of good information. And on the sleep tests, you'll want to be paying attention to the key metric that everybody's using today is still the AHI or the REI or the RDI, but really down range, we're going to see a movement towards sleep apnea specific hypoxic burden. So go look that one up. We don't have time tonight, but it's a measurement of the severity of the events instead of the frequency of the events, because two people could have 30 as an AHI, and one could be 30 very shallow desaturations that didn't last long, and the other could be 30 very severe desaturations that lasted 30 seconds. Which would you rather have? I'd rather have the shallow short ones than the deep long ones, for sure. That speaks more to the cardiovascular risk and all-cause mortality. Nadir is how low they go. I like to focus in on discussions with patients if I'm talking to them about feeling better, sometimes talking with physicians about time under 90, pulse rate. And then if your sleep test gives you positioning, or if your sleep test gives you some algorithm that they use for sleep staging, that can be very helpful to talk about. In this position, Mrs. Jones, on your back, you notice you still had a much higher AHI. You told me you weren't able to sleep on your back before. Now you are with your oral appliance, which is fantastic. But if we could get you on your side with some positional therapy, we might be able to do a little bit better. And then you'll see some patients who got very little or no REM and felt really disoriented a lot during the day. And now they're getting, 20 to 25% REM. And of course, your AHI will be higher in REM. So this information that we can get from these sleep studies isn't just for the physician. Sometimes it's for us to have a good conversation with the patient about what we see, not an interpretation, not a diagnosis, but a meaningful conversation about why they feel better, or why their numbers haven't changed much and they feel better, or what we can do to help nudge those numbers along. And always do that in concert with your physician. So best practices in testing: have a relationship with a telemedicine construct that lets you quickly get patients tested and is very oral appliance friendly, so that you get back the prescription and the LOMN. Most of them will require a telemedicine visit before and after the sleep test. That's where they make their money. They make a couple $100 on a sleep test, 2 to 3, and 50 to 75, $90 maybe on the telemed visits at both ends. And that's their income stream. And if you protect that for them, they'll look out for your needs as well. Okay, so now we've found some patients in our practice. We've gotten them tested. How do we treat them? Call Frank and find out what kind of devices he's recommending. That's for sure. But really, when we're starting to think about treatment, I want to have a very good conversation with the patients, because patients don't usually come in and say, hey, I feel like my AHI is high. Can you lower it? They come in and say, I feel like crap. I'm snoring. My bed partner's gotten out of bed. My dog's gotten out of bed with me, whatever it might be. And so if we think about the old adage of what was their chief complaint, and keep that in an orientation, because we can't always solve those problems. We can't always get them to sleeping better and feeling better. We can't always lower their AHI. These oral appliances, these precision oral appliances that Frank makes, they only work about 90% of the time. That's great, but it's only 90%. That means 10% of the time, we have to have a conversation with the patient saying, I'm really sorry this didn't work. They don't get their money back. This is medicine. And you didn't prescribe it for them. The physician did. And the treatment that they prescribed just didn't happen to work. That happens in medicine all the time. We got to think like a physician, not a dentist. We got to think about discussions around money, billing medical insurance, and treatment outcomes like a physician. And in severe patients, they only work about 80% of the time. So we want to get the HI down below 10 and a 50% reduction. We want to get rid of the subjective signs and symptoms that the patient complained of, but they don't always go together. Sometimes snorers stop snoring and the AHI doesn't come down. Sometimes the AHI comes down and they're still snoring. Usually they go together, thank God. We also want the patient to be able to wear the device every night. We don't want soreness, bite changes, tooth movement, so we want to minimize side effects. We don't want reactions to the tissues, toxic reactions, allergic reactions. So we want good patient safety. And that's what's really great about milled devices like Frank makes, or these nylon devices. They're very inert and strong. And we also want to have devices that we make sure we use the right device for the patient that's going to be covered by their medical insurance. Some of them have specific requirements for different kinds of devices. From a treatment sequencing, we'll talk first about informed consent, exam, and records, of course, and then we'll talk about all of the other treatment modalities. And the best practice I want you to think about here is two things. Number one, can the patient wear an oral appliance? We're not doing a dental exam to be their dentist. You might be their dentist if you're screening these patients, in which case you should have already done a comprehensive dental exam and you just layer on top of it anything you need to make it a comprehensive oral evaluation for an oral appliance. But if I'm a dentist who's doing this and I don't have any patients, I didn't, and I'm relying completely on referrals from other dentists or physicians, my assessment of the patient isn't measuring periodontal pockets, isn't taking a full mouth series of radiographs. It's asking and answering the question because the physician has ordered this patient to wear an oral appliance. And much like a knee brace for an orthopedist, I'm going to look at the patient's knee and their skin. Can they wear a knee brace? Are they intelligent enough to adjust the knee brace? Can I show them how? Do I size it correctly? Do I fit it? I have them back and titrate and adjust the knee brace, valgus and vargus. Same thing here. Can the patient wear an oral appliance? And edentulous patients are challenged for sure. People say to me all the time, how many teeth? Excuse me. And it's not so much about how many teeth. It's about where are the teeth and how solid are they? You could give me 4 teeth or 4 implants in an arch, and we can rock that if they're in the right spots and they're rock solid. Most people that only have 4 teeth don't have 4 rock solid teeth in the right spots, but you get the idea. It's not about that. It's about can they have a little bit of perio? Yes. Can they have a little bit of decay? Yes. Can they need a future crown? Yes. You can adjust that device here and there. So can they wear an oral appliance? The second best practice is from the early part of the treatment is, do we go through the informed consent with them verbally and explain what's in the document? Jamie Machinsky, who only does sleep medicine and really works a lot with oral appliance manufacturers and billing companies, says that the piece of paper that you have the patient sign will not hold up in a court of law unless you've explained what's in it before they sign it. That's a really important consideration. So we talk about the side effects, the risks, the benefits, and most of the side effects today with precision oral appliances have been minimized, but we still cover them off. From a treatment standpoint, we'll take exquisite impressions, whether we're scanning or not. If you use Silginate, Frank's going to beg you to use a 2-stage putty wash technique with saran wrap over the putty. Let that completely set, remove it, do a wash, and you'll get this Invisalign-like impression, which makes it easier for the device to be made and makes it easier for you to deliver and seat. And I promise you that additional cost will eliminate so many. Yep, thank you, Frank. Thanks for nodding. Will eliminate so many of your remakes that it will pay for itself. Because if you have just a 10% remake factor, or you spend 10 or 15 more minutes adjusting a device at delivery, well, what's your chair time worth? And if it's $400 an hour as a dentist and $1,600 an hour doing sleep, that's a $400 expense for not doing a better impression. Plus, you don't have to do the impression. Your team can do it. You can teach them to do a putty wash. And I'll tell you, I remember standing at so many of these dental meetings and advising people to try the putty wash. And Frank, we had a really good relationship with Kettenbach. You know the folks from Kettenbach, and they'll send you a little starter kit for like nothing. And they'll get some putty, they'll get some wash, and we all have saran wrap at home or headrest covers or something we can put over those. But man, does that work great. If you're scanning from a best practices standpoint, the biggest mistake we can make, over scanning and chasing all those little nooks and cranny in a full arch impression, I've been told by every manufacturer, can corrupt the file. I would have thought I would just made a big file. They tell me it can corrupt the file and change the arch form a little bit, and then the device will be usually way too tight and you'll have trouble fitting it. So
Mark,
if you,
I'm sorry to interrupt. May I add a little bit to this in
oh,
terms of
please
the
do, Frank,
quality?
absolutely.
Just thinking from the perspective of side effects and potential tooth movement and things like that. Um, so even with perfect scans and perfect impressions, there's still that potential for side effects. So clinically understand that is possible. We do everything we can to minimize it. But if the quality of the scan or the impression is not there, then I would imagine that would increase
Goes up
that risk.
tremendously. Absolutely right.
Thank
100%.
you.
You are so right. Just like today, we don't see much tooth movement like we used to with the older devices. If you gave Frank a crappy impression and you said make it work, he puts 4 ball clasps in it. That's what we used to do. And then it only fits at the 4 ball clasps, and the rest of the teeth are loose and ready to move around. With these milled devices that he's got and these printed nylon devices, they're going to fit very accurately. and they're going to wrap around the distal of the second molars, you're just not going to get any tooth movement, but you can still get bite changes. So you can still have other kinds of side effects that you want to worry about for sure. Most of the offices, I'm sure that you're seeing, Frank, too, are taking bites using a George gauge. There's lots of other ways of taking a bite, but I'll tell you, if you're getting started or you want to scale, this is quick, it's easy, it's very accurate. There's a great published study that, again, the resource people at True Function can access for you. It was published a few years ago by a fantastic clinician, Kim Monroe and Mark Murphy. Oh yeah, that's me. Where we demonstrated that at 50% of the range of motion, we already solved 40% of the patient's AHI reductions, and within 2 millimeters, 80%. So this idea of about half of the range of motion with the newer precision devices that Frank makes, that you see from a lot of the manufacturers today, they're smaller and they require less protrusion. They're easier for the patients to wear, fewer side effects, better patient safety, etc. So that's a tremendous advantage. And we don't put any goop on the bite forks when we're scanning. That's just for an analog impression technique, but it works very, very well. Where do we start? 50%. How do we know when we're there? Subjective signs and symptoms, maybe a pulse oximeter, maybe the patient's wearing an HST ring, and we're monitoring them as we move them a millimeter forward. There was just a published paper recently at the ADSM and the AASM by a guy named Tozer, Chuck Tozer, that was fantastic. And it demonstrated in, I think, 55 successive cases as a prospective study that they looked at doing what they called fast track rapid titration. It's been something that some people have been doing for a couple of years. Guy Yatros popularized it a couple of years ago and talked about it a little bit, but never had we seen a study that demonstrated objectively the scientific evidence for it. Chuck pulled out any of the patients that might have had some TMD issues, especially internal arrangement, so he didn't do this with them. But everybody else, he sends them home with their device and a ring and has them wear 0, 0 the first night, and then has them go forward 1, 2, 3, 4 millimeters the next 4 nights. So 5-night test, then bring the ring back in. He loads up the data and says, this is the position that you're best in. So it's rapid titration, takes 4 or 5 days, and you find the position. He can get a patient from impression to treated and back to the physician within 30 days. That's really remarkable. What do we do then? Well, then we've got to still advance the patient. We got to confirm. So it's imperative that in our talk track, we make sure that the patients are going to go back for the follow-up HST. So you've got a diagnostic HST read by a sleep physician. Then you treat them. Then you've got an efficacy test with the boarded sleep physician. We were lucky if half our patients went back for that follow-up test because they felt so good. They felt so much better. They weren't that concerned with trying to get back and getting that done, even though they know they're supposed to, and we encourage them to. And it made a lot of our studies when we would publish papers took us twice as long because if you wanted 50 patients with pre and post studies, you might have had to do 100 patients to get 50 with pre and post studies. So it's always a little bit of a twist track. So what's our best practice takeaways from the treatment? Use precision devices, precisional appliances. Make sure you've got a great informed consent conversation with the patient. Okay, that's imperative. Your exam should focus on, can the patient wear an oral appliance if you're not their dentist? If you're going to become their dentist, come back and do a separate dental exam on them when you see them as a dental patient. If you're already their dentist, you've probably already done that. So you're covered there either way. And then certainly from a treatment standpoint, make sure you've got these great impressions, good devices, precision devices like you're getting, so that you have fewer side effects and a better patient safety profile. So from a treatment standpoint, you'll get better success, fewer complaints from patients and physicians. That's very helpful. My favorite part to talk about nowadays is documentation and billing. And it's almost counterintuitive because as dentists, we want to talk about the clinical aspects of treatment. And we think, often, mistakenly, unfortunately, we think the better we get at taking the impression, the better we get at taking the bite, and the better we get at using a device, the better our results will be. And although that might be true from a clinical perspective, none of that really has a significant impact on getting paid. And I can assure you, if you can't get paid, you won't do much of this. That's why there's 100,000 dentists that have taken a sleep course, maybe 6,500 that have ever made an oral appliance, and maybe 1,500 that have ever billed medical insurance, and only maybe 4 to 450 that have ever made a business out of this. It's because of finding a way to get paid. And that starts with proper documentation. It turns out that billing medical insurance is completely different than billing dental insurance. You can't use your dental software. You can't use Dentrix, EasySoft, any of those kind of things. You have to have a separate EMR. It's a very complex process. Each insurance company can have its own eligibility rules, its own coverage and benefit rules, its own clinical guidelines for how you're going to treat the patient to get paid. You can treat the patient however you want, but to get paid by the third party, and that's where this becomes scalable. Otherwise, you'll do 1 or 2 devices a month or a quarter the rest of your life and say you do sleep. And if that's your goal, I'm okay with that. I think it's a little odd because you could do so much more. Working with medical insurance means you get to do a much better volume, and oftentimes you get paid much better, especially when you look at some of these reimbursements from Medicare with supplements. Holy cow, 6, 7, and sometimes $8,000. And you get a lot of slow payments and denials if you don't have the right systems in place. The key things to getting paid are proper documentation. So the software has to, and this is what we've got available at Restful. And you don't really see this with the other softwares. I'm sure they'll all catch up soon. But right now at Restful, we make sure that you input. You can't go from A to B to C to D and press submit on the claim unless you filled out all the boxes. Why are we so crazy about that? Why do we spend the first few weeks training you up on that? Well, because if you don't fill out the forms right, you won't get paid. And if you won't get paid, we don't get paid. And we want you to be successful. See, think about this webinar. Frank wants you to be successful. Why? He wants you to be successful doing more sleep devices. Why? Because he's going to sell more devices to you. And I want you to be successful billing these devices and getting paid. Why? Because that's where we make our money. The software is dirt cheap. It is. A couple, $300 a month. No big deal. It's the billing. And if you're only doing a couple or 3 devices a month, that's great, but you're not making any money. We're not making any money. Frank's not making any money. We want you to be doing 10 or 15 or 20 devices a month so that you've got this day and a half or 2-day a week lifestyle. You have this 2-day work week. That'd be fantastic. Still have $1 million practice with low overhead. And Frank loves it because he's selling you devices off the shelf like crazy. And the billing company loves it because we're making money on the claims. So this software was built to create this guided documentation. The second thing it has is it's connected to over 300,000 insurance payers across the country through a special portal system. It's a separate fee for that. It's just a pass through, just like credentialing with the insurance companies and with Medicare. It takes time and money. But once you get those connections and you have this portal, you can do instant, accurate eligibility checks and benefit checks. You can't do that with any other system. So that makes sure you've got a live patient in the chair that you can actually treat and get paid for. That's what's critical. And this speeds up the claim process. I was telling Frank before we started, there's this interesting law called the Clean Claim Act. It's in all 50 states. If you submit, hard to do, but if you submit, almost impossible, if you submit a perfect claim, every box checked correctly, every T crossed, I dotted perfectly, the insurance company by law has to pay you within 30 days. At Restful today, we're averaging, we hate to even say this number out loud because it's well within the 30 days, but we're averaging 16 days turnaround on the claim time and over 95% properly paid within the first 30 days because this software forces you. The average reimbursement is about 70% of the claims getting through, and the average turn time for other companies is about 45 days. So it's a remarkable difference in moving that cash flow up into a manner that you can use it more meaningfully. There's really good support of a product like this, whether it's text, whether it's email, whether it's live chat. That's Christy Fink. She's the billing guru. We lock her in the back room and she makes all these kind of great contacts and decisions. She's set up a lot of the relationships with the portals to the different payers and everything so that you can make sure that everybody gets paid. If you don't get paid, it's going to be hard to develop a business model. It'll be hard to invest the time, effort, and energy in really doing this successfully. I can count on one hand, just using probably 2 or 3 fingers, the number of practices I know that have successfully built a business model on a cash basis for oral appliances. Without working with Medicare, because physicians expect you to, enrolling, but not participating in the fee schedule. So enrolled and credentialed, but you want to be able to bill their supplemental insurance. And without trying to be a network or playing like you're a network, or at least working with the insurances and billing the gap, you just can't look at physicians and expect them to make the kind of referrals we need. And you're going to need that eventually, because once you screen your patients for a couple of years, unless you have an incredibly large new patient flow, you're going to eventually run out of patients that you can see. So having some patients available and working with some patients on the outside side are advantage to you. Um, so our best takeaway on the billing and documentation side is we need to have a system, a predictable reimbursement system. And I want the software because software is, once you make it, you can sell it over and over again. It should not be expensive. RESTful software is very inexpensive. The billing per claim, you don't want to do something that's on a percentage basis when you get those $7,000 and $8,000 claims, which you are going to get. You don't want to be paying 8 or 10 or 12% on those. You want a flat rate. And then you want something that has a guided documentation and connections with the insurance companies with these portals. And then you can have a predictable reimbursement model. In fact, we are so insistent on making sure you do things the right way and so insistent on wanting you to be successful. We actually give people that are just signing up for the billing and software 12 weeks of coaching to help them get started. Not just started on the billing platform, but started making sure they're doing all of the kinds of best practices we're talking about tonight to guide them and coach them a little bit so that they can be successful. Why would we give away 12 weeks of free coaching? Because we want you to do a lot of claims. You do a lot of claims, we make money, Frank makes money, everybody wins. Because I'm going to tell you, if you're doing 15 or 20 devices a month, 30, 40 devices a month, you're going to be ecstatic and you'll be happy to pay for those claims. You'll be happy to pay for those devices. If you're struggling to do a couple of devices a month and you're worried about your fee because you're having trouble charging $2,000 or $3,000 or $4,000, the average client, the average member for RESTful is probably charging $6,000, $7,000 or $8,000. I've heard some in the nines. Why would they charge so much, even though their cash price or their prompt payment discount might be 25 or 35 or $4,000? Because some insurance companies pay that and you don't want to give that opportunity away. And that helps bring your average up just a little bit so it makes sense. If you've got any questions, want any more information about what RESTful can or can't do for you, what the different kind of coaching platforms are, or you want a copy of the slides or anything from me, or you want the slides that I use when I'm doing a consult with patients, I have an 8-slide deck that I use for that. Feel free to email me at mark@ios.com and I'll be happy to send those to you. I mentioned a couple, 3 articles that that the folks at Truth Function can access for you. And again, if for some reason they can't get those to you, reach out to me. I've got access to all those as well. Best practices, what do we need to do? We need to get patients, probably the easiest way, mining right under your feet, screening your patients, intentional conversations. I need to get them tested. I need a relationship with a third party, teleportal, telemedicine kind of visit. I need to treat them with great devices, taking better impressions. So I've got techniques that make it easy and streamlined that again, you don't have to do. You can train your staff to do it. You have to do the exam. You have to be there and attest to that. That has to be in your SOAP notes for most payers, but man, team can do just about everything else. And then you got to have a predictable reimbursement model with guided documentation and portal access to all insurance companies. If you do those 4 things, you're going to be successful as hell and sleep. Mark@ios.com. And now, Frank, I'm handing it back to you, my friend.
Thank you, Dr. Murphy. One thing that really stuck out for me is the reimbursement time with RESTful I was in a conversation with a clinician earlier, I think it was today, and the frustration of waiting multiple weeks, maybe a couple months or so to be reimbursed, which of course it affects your cash flow and it makes it so difficult to operate a business if it's taking so long to be paid because you got to pay everybody else, got to take care of everyone. So this is amazing. It's a great opportunity, and so thank you for sharing your valuable knowledge, Dr. Murphy, and we really value the information you're shared.
As I was telling you earlier, we've been adding so many new members every month now, and my big worry is if we had 40 or 50 new members come in tomorrow,
Yeah.
is the scalability of the entire system. Right now, we're doing great, gangbusters, but we can only add people at the right rate we can. So it's not like we're trying to limit who comes in, but man, it's a daunting task to keep all these parts. The clinical guidelines keep changing. The insurance companies change them quarterly because they don't want to pay you. They want to find a way to not pay you. And the latest ones are you didn't say in your SOAP notes that you were actually physically present in the operatory doing the exam.
Mhm.
How the hell else did I do the exam if I wasn't there? Right? Well, they're worried that it might be a telemedicine visit, so they're going to discount it. If you didn't say you were physically present, they don't pay, and they don't tell you why they're not paying. So if you don't know that clinical guideline, nobody tells you to put that in. Was the test at 3% or 4%? Oh, we could go on and on. You know the drill on that. So anyhow,
Thank you.
a couple good looking
Well,
devices there. I tell you
we
that.
thank you. We again thank you for your generous time and sharing your expertise, Dr. Murphy, and yeah, you're again a good friend and a blessing to be with True Function to support us in the webinar. Just a promo for everyone. We got True Herbst and True Dorsal for really good pricing, and so what you'll use is the promo code is IAOS 2025. So that's good through the end of October. Take advantage. It's gonna get busy for all of us, of course. End of year is everyone's busy time. So if you haven't tried these devices, please give them a try. We do have an upgrade to the different materials, but please give those a try. There is for those of you that are new to us, there's I believe in the chat there's a link to set up a new account for us with us. And just a quick note for next month, the webinar is November 11th. It's Dr. Mayor Patel, a good friend as well, and so that's
He's a great lecturer. You can tell him that I said he's the second best lecturer I've ever
the
heard.
second best, of course. Yes, no, amazing and wonderful, and again a great friend to us, and a brilliant clinician. The second most brilliant clinician, of course, Dr. Murphy. So thank you. Looking forward to that. And these are the places that we will be towards for the rest of the year. So we're looking forward to seeing some of you. And I believe that's it. We will be emailing the webinar to those of you that attended. And I think that's it. I thank you all for taking your time, investing your time with us. And yeah, thank you for all your support. Dr. Murphy, again, thank you for everything. Thank you for being here, and thank you for sharing such valuable information.
Frank, it's always my pleasure. I really appreciate it. And I can see you're at some really good things. Awaken to Sleep does a nice job. That mini residency is great. You're at the AACP meeting. They've got an interest in sleep, as all prosthodontists would, as well as certainly TMD, and you do a great job at that as well. And then again, Mayor is a great lecturer, so speak highly of him
Thank,
for sure.
thank
Well
you,
done.
Dr. Murphy.
All right. Thanks,
Well,
Frank. Take care.
well, everyone, have a
Night,
great
everybody.
evening, and thank you so much, Mark. We appreciate you.
Email
See you
me.
soon. See you
Peace.
soon. Thank you.